basic questions that we start off with. See, I'm going to keep this quite general, and I'm not going to go into the specifics of things, so that each one of us has an idea at the end of the talk. So let us start off. We always start off with, when you see something happening to a patient, a seizure is it a seizure? That's what it is. So, because there can be seizure mimics, and so therefore we have to decide whether it's a seizure, an epileptic seizure, or a non-epileptic seizure. And if it is a seizure, then what kind of a seizure is it? Is it a motor seizure? Is it a non-motor seizure? Is it just absence? Is it all these kind of things? The next important thing is that we have to find out is, if it is a seizure, then what actually caused it. You have to understand the etiology of it. And then obviously when you have a seizure, then what should be done for it? So each of these will be addressed over the next few. Right. Then the other thing is, then when the patient recovers from the seizure, you'll have to ask the patient, is this, have you already been having seizures? Has a diagnosis been made earlier itself, and are you on treatment? Or is it the first ever seizure that you have had? So this is very important to distinguish between the two. The two groups are different. So this is how we approach a patient with seizures. But before that, you have to understand what exactly you mean by an epileptic seizure. An epileptic seizure is nothing but, the brain consists of billions of neurons, and they are all connected to each other by means of their dendrites and axons, as you can see in this figure. And they communicate electrically. One neuron communicates to the next neuron by means of the electrical flow from the nerve cell, which is the neuron. It goes along the axon, it goes to the dendrites, it catches the next dendrite there. So this is a dendrodendritic, an axodendritic connection, and then the electrical impulse from one nerve cell will go down, go to the next nerve cell, and so on and so forth. So that is how we all communicate. Each part of the brain communicates with the other part by means of electrical signals, and that the electrical signal will then convert it into a chemical signal, and then that's how there is an electrochemical gradient, and this is how all our normal functions happen. If I'm talking now, my left frontal lobe, my Broca's area has to be intact. That's how I can talk. If I have to understand, my Wernicke's area has to be normal. Now, how is it normal? Well, it is my brain is functioning normally at the present time because I have the proper electrochemical milieu, and that's why I'm able to talk. You are able to listen. So all of us are quite normal. But then one group of neurons then decide that, okay, we are now going to fire synchronously. And there is a rapid, excessive electrical discharge, hypersynchronous. If 10 people get together and they say, okay, we are going to make a noise now. Now let's do an electrical burst of activity. That is what. So there is an excessive electrical discharge coming from a group of neurons, nerve cells, and they communicate with the others, and they disturb the rest of the brain by this excessive hypersynchronized discharge from one group of neurons. So that is what you mean by an electrical seizure. But then we'll have to know what exactly you mean by epilepsy. Is a seizure synonymous with epilepsy? So that's what we'll have to look at. So for which you have to have an idea of what is epilepsy. So an epilepsy is diagnosed when somebody has two unprovoked seizures. We'll come to what is provoked and what is unprovoked, but at least two unprovoked seizures occurring more than 24 hours apart. So if somebody has two seizures within the next 15 minutes, although it is two seizures, it is not epilepsy. But if you have one seizure today and one seizure 24 hours later, then that could be epilepsy. And nowadays, you can actually make a diagnosis of epilepsy even at the end of one seizure. I'm not going to, you don't have to go through the rest of this slide. I just have to tell that if somebody has the first seizure, and I'll give you some examples of that, and then the patient has not had a second seizure yet, so could you call that epilepsy? In certain circumstances, you can. And I'll tell you what circumstances. You don't have to, I'm not going to complicate it anything more. But what I'm trying to tell is, generally, epilepsy means two unprovoked seizures 24 hours apart. But in some people, even at the end of one seizure, you can make a diagnosis of epilepsy under some circumstances. And I will come to that. But what is not clearly epilepsy? Clearly, these are not epilepsy. One is a single seizure, except for in that circumstance that I told. But if a seizure is provoked, even if you have 10 seizures, it is not epilepsy because they all come in a certain setting. So if a seizure is provoked only by fever, only by hypoglycemia, some metabolic disturbance, hyponatremia, alcohol either abuse or withdrawal, drug abuse, drug withdrawal, all these things can produce seizures, flurry of seizures. Just because there is a flurry of seizures, it is not epilepsy. So these are very, very, very important. Single seizure is not epilepsy except under some circumstances. Provoked seizures due to some metabolic or toxic factors, they are not epilepsy, even though they are multiple seizures. Right. So then you'll have next question is, if it is a seizure, then you have to have a clear understanding of how to classify them. And so this is what the schema is. If you have to classify them, you'll have to classify it like this. A seizure can begin from one part of the brain, and that's what you call it as a focal seizure. Or the seizure can begin and involve the whole brain rapidly, and that's what you call as a generalized seizure. Sometimes you're not aware of whether it is focal or generalized, then you call it as unknown onset. So these are the seizure types. So focal seizure, generalized seizure, sometimes you don't know whether it's focal or generalized, so you call it unknown. Immediately when you see somebody has a seizure, you'll have to go to the etiology. And the etiology will then determine what tests you'll have to do. So that's what it is. So immediately you have to get into what is the cause of the seizure. Remember that second question that we asked, what caused the seizure? And so you'll have to have the schema immediately. Is it structural, which means is there an abnormality in the brain structure? That means is there a tumor, or is there a inflammation? Is there an infection? And is there a gliosis, a trauma, whatever it is? There could be some underlying genetic factors, and that can produce a seizure. Infection is very common in our country, so neurocysticercosis is a very common factor, and tuberculosis, meningitis, and tuberculomas. Metabolic disturbances can produce seizures. Immune disorders of immunity can produce seizures. You have these what are called autoimmune seizures. And despite our armamentarium of various tests, this group of patients, you will not be able to find out the etiology despite all these tests. So then you call it as unknown or idiopathic. Once somebody has two seizures, then you call it an epilepsy, and then again in epilepsy, because they are recurring seizures or recurrent seizures, then you call it an epilepsy. So you'll have to classify these epilepsies as focal, if it is starting from one part of the brain and then remaining there, or can spread. Generalized, if large parts of the brain is simultaneously involved, that's you call it as generalized epilepsy. If the same patient may have combined, sometimes focal, sometimes generalized, so you can have a combination in the same person. And again, despite all our history and examination and all that, you may not be able to exactly determine whether the seizure is a focal or a generalized. And the next one is that once you have these epilepsy types, focal seizure, I've made a diagnosis of focal seizure. And if a focal seizure is happening at a particular age, say 5 years of age, and it's a focal involving only the hand, the child is otherwise normal, And if the EEG shows a particular pattern, then I know, okay, this is an epilepsy syndrome, a benign or a self-limiting epilepsy syndrome, benign Rolandic epilepsy, for example. So that we know that you don't have to treat much. So the epilepsy type will then help us to determine, along with the etiology, will help us to determine the epilepsy syndrome. So seizure type, epilepsy syndrome. And no patient with seizure is free of some form of comorbidity. Comorbidity means some other existing abnormality. For example, they may have some psychiatric conditions, they may have other metabolic conditions, they may have other medical conditions. So these are what are called comorbid. So you have to look at the patient as a whole. You can't be just only focusing only on the seizures. You must look at the patient as a whole and understand. For example, somebody may have diabetes and epilepsy. So you'll have to address both the things simultaneously. And you cannot say that, okay, I'm going to look only at your seizures. I'm not bothered much about your other comorbidities. So that's how we look at the patient as a whole. Now let us look at it from a slightly a little more in detail about what is a focal onset, what is a generalized onset, and so on and so forth. So focal onset. Focal means a small part of the brain is involved. And two important points here. You may have a focal seizure, but the patient may be fully conscious and aware. That is what is called a focal aware seizure. Focal aware. Or the seizure may be focal, but still the patient may become unresponsive. And therefore it's called focal onset with impaired awareness. That means the patient loses awareness of the surroundings, becomes unresponsive. And it could be motor or non-motor. And the focal can actually become bilateral tonic-clonic. It can spread to the rest of the brain and becoming bilateral. So it can become diffuse and generalized. So focal to generalized. So that is how we can classify. Now generalized, again, you have this motor and non-motor. Motor means, you have these jerking, tonic, clonic, myoclonic, and all that kind of things. In non-motor, there is no motor manifestation. They just become silent. So that's what is called an absence. So this is how we can actually classify seizures, and you can also classify epilepsy in the same manner. Now, I'll just give you a cartoon about what do you mean by generalized. You see that, it starts somewhere, but immediately the whole brain gets involved. So, the networks get involved very rapidly. You see, it has started in the left frontal region here, but it is not confined to the left frontal. Immediately it involves the whole brain. The whole brain gets zapped by this excessive electrical discharge. Therefore, the person becomes immediately unconscious and can fall down and becomes densely unresponsive. So that is what it means. So I'm not going to go into that. On the other hand, you look at this. Focal seizures have a very discrete origin. See, for example, this is a focus. This is a very, very small focus. But as opposed to the previous slide where you had a focus, but it involved very rapid generalized, here it involves only very local network. That is why it remains only confined to one area of the brain. Because only a small area of the brain is involved, the awareness may not be lost. Or if a little larger area is involved, the awareness may be lost. And it may sometimes be remaining only in that region, or it can sometimes go to the other side. And when it goes to the other side, usually you lose awareness. So, but whatever it is not involving the whole brain. It is involving only part of the brain. That is the difference between a generalized seizure and a focal seizure. So remember that. That's a very, very important point. Now, I was just telling you at the beginning, is it a seizure, is it epileptic or not epileptic? So there are, sometimes, because epileptic seizures arise from the brain, but then there are other seizure types which may not arise from the brain. The brain only gets secondarily involved, it's not primarily involved. And some of the common conditions are syncope. Syncope means, you have a vasovagal attack, the blood flow to the brain stops for some time, and the person loses awareness, can fall down, and can actually have a few clonic jerks. That's what is called a convulsive syncope. So that is how, so just because somebody has some jerking, it doesn't necessarily mean it's an epileptic seizure. It can be a convulsive syncope. Stokes-Adams, suddenly the heart stops, the rhythm stops, and then the person has hypoxia transiently, and then they fall down. Sometimes sleep disturbances, parasomnias, they are called sleepwalking, night terrors, they scream in sleep. That also is paroxysmal, and so therefore hyperventilation. Sometimes you have these funny stereotypic movements, motor movements in children especially. And sometimes you can, some people are just absent-minded. They just keep staring, but they need not necessarily be having absences. So these are some of the things. And very, very important, about 20% of the patients may not have seizures that arise from the brain or from the other parts of the body, but it could just come from the mind, disturbed mind. So psychogenic non-epileptic seizures, about 20% of all seizures are. The clues to the diagnosis, very, very important. When you have a generalized tonic-clonic seizure, you watch any patient who's having a generalized tonic-clonic seizure, the eyes are always open. The patient is unaware, the eyes, their eyes roll up and they just look blank. And in this patient, in these nuisance, non-epileptic seizures, they keep their eyes closed. They resist eye opening. And they always have multiple attacks. And in seizures, epileptic seizures, one seizure will be the same as the next seizure, They are very stereotyped. But in non-epileptic, they can vary from one seizure to another. And in genuine epileptic seizures, many times they arise from sleep. But in non-epileptic, they never arise from sleep. And invariably, a non-epileptic seizure, psychogenic non-epileptic seizure, usually happens when there are people around. That means they need an audience. Otherwise, they don't do it. It's a waste of effort. So that's what it is. So having said that, I'm now going to show you some examples, because usually, you never come across, how many of us have seen actual seizures happening in front of us? Very few, very rarely. So we don't come across. But as epileptologists, we, when we investigate patients, when we do long-term video EEG, we get to know, we get to see a lot of seizures. So we become good at identifying. So therefore, I'm going to show you, what are these generalized seizures? What are these focal seizures? I was telling you, focal seizures with preserved awareness, focal seizures with impaired awareness. I'm going to show you some examples. So let me start off with the generalized seizure, because this is very important. And these can be diagnosed in the clinic, in the outpatient. I'm going to see what I'm going to do for this boy. He's about a 9-year-old boy. Just watch him, see what he does. I'm asking him to hyperventilate in the clinic. And he's hyperventilating, and now he's unaware. He's not answering my question. Eyes are open. You saw that? So he responds as soon as, so he was densely absent for about 5 seconds. And this usually happens during hyperventilation. And they stop breathing. And you saw that, then the eyes roll up and he's not able to answer questions. And then after 5 seconds, he becomes normal. This is another example, another boy. Yeah, now he's absent. You see, he's staring, he's blank. Yeah, so he is immediately able to talk. So you see these two examples. Now this didn't require any sophisticated testing. All it needed was no instruments, nothing. You can do this in the outpatient. So this is what is called a generalized. This is one type of generalized seizure and non-motor, because there are no motor manifestations. So that's what is called generalized seizure absence. And this will be the EEG. And the EEG, if you do, it'll look like this: 3 Hz spike and wave. And you know that, oh yeah, this is a childhood absence epilepsy. So that's the epilepsy syndrome. So you know the seizure type, you know the epilepsy type, you know the epilepsy syndrome. Okay? Now I'm going to, so you just see now, this is very rare to get these. So one of our patients will be recorded. You just observe the hands now. Slowly it will come. Are you able to see the videos? Yeah. So now those are the jerks. You see this? That's myoclonic jerks. See, sudden irregular jerking from myoclonus, which is bilateral. Now it is tonic. You see the hands are stiff now, legs are stiff, and there's an epileptic cry. This is called an epileptic cry because there's a vocal cord spasm, and now that's a tonic phase. This is the tonic phase, and it is generalized because it's bilateral. And now it's going into what is called the clonic phase. So myoclonic, tonic, clonic, and it's bilateral, it is generalized. So this is a generalized myoclonic tonic seizure. And you see the nurse, the nurse is very calm. You see that? The nurse is very calm. The nurse is not doing anything, and that's how it should be. It's only at the end of the seizure that the nurse gets active. The nurse will then turn the patient to one side. That's all is to be done. That's it. They'll recover very quickly. There's no need to put this kind of that. You should not intervene during the active phase of the seizure. Okay, so that's what it is. So, okay. Now, you can get in children devastating. You can see this. One of the times you should never miss this. Small child, yeah, that's what is called an epileptic spasm. This is called an infantile spasm. This is a small little kid, it's only about 6 months old. And this child has been getting these attacks. You see this, I'll again show this. You should never miss this because the parents will just describe this as some kind of, my child is getting these kind of jerks. Never ignore it because early treatment can help them and the child can then become encephalopathic. So you've got to treat them very quickly. Just watch this. This is called an infantile spasm. This is a spasm. It's a sudden bilateral arm abduction and flexion of the legs. So that's called an epileptic spasm. It's also a type of a generalized epilepsy. And I'll show you some horrible, very injurious child. Oh, that's a very bad fall. You see this? This child has fallen. And this is what they'll have injuries to the forehead because they fall forwards. And this child has fallen in front. Yeah. So this is what is called a tonic head drop, tonic drop attacks. This is called drop attacks. And these drop attacks can be very injurious. And just suddenly and then they injured the forehead. You can see it's another injury to the forehead. It's very bad. So you can see that they can injure themselves very badly. So these are also types of seizures. They are called drop attacks. Drop attacks. Now we'll come to focal onset seizures. Again, I said that focal onset can be aware, can be unaware. And again, it can be motor, it can be non-motor. So let us see some examples. And it can be focal but becoming generalized. I have some examples of it. Watch this gentleman now. Just see what his leg is. Now you now see what happens. Okay, so his leg is raised. See, suddenly his leg has become tonic. It's a motor activity. It's a tonic leg flexion. You see that? And some jerking of the leg. And he's aware. He's telling the technician, see, I'm getting this tightening of the leg. So he's getting a tightening of the leg. So that is a classical focal motor seizure involving the right lower limb. But awareness is preserved. He is fully aware. He is actually describing to the technician that, okay, I'm getting this attack. So that is a focal motor seizure. Another example, yeah, you can see that, his hand, you see, these are called, these are myoclonic jerks of the hand, intermittently coming. And he's aware, he's fully conscious, he's talking to me. He's saying it's automatic, he's not able to control because it's happening. So that's what is called a focal seizure. It is motor because there's a motor movement. And he's aware because he's talking to me. And so that's a focal seizure, right? So, okay. But now, I will show a focal seizure, but the patient is unaware. She may be probably aware, but after that she is not able to respond. You see this? This is what is called earlier days it used to be called complex partial seizure. It's not. You see, she's appearing confused now, and she appears confused. Definitely, she's confused. She now tries to gesture because she's not able to talk. She says that something is happening to me, but she's not able to tell that. She's only gesturing. And she's now confused. So that means focal. She's now, see, she's not able to respond. The previous patients we could talk. And you see the right hand is becoming stiff. Left hand is free. That's called automatism. You see, waving hands. Left hand is free. Right hand is a bit stiff. She's a bit fidgety. She's confused. She's not able to answer any question that my technician is asking. So this is a classical seizure. And see, at the end of the seizure, my technician is trying to ask her to name some of the objects. She's not able to name. See, that's me there, and I'm asking her questions. She's not able to answer because she's completely confused. And so this is what is called a focal seizure with impaired awareness. Some motor features are there, and so that's what it is. Now I'm going to show you a focal seizure, but this is a lot of movements, motor movements, and hyperkinetic. You just see this. This can also be one type of seizure. It's coming from sleep. Oh yeah. So that's called repetitive movements, stereotypic repetitive movements of the hand. It's very unnatural, isn't it? The left hand is stiff, the right hand is moving freely. And you see that? So this is also a type of seizure. Repetitive hyperkinetic movements. And you will not believe that this is a type of, this is also a type of seizure. And then there's that body turn. You see that? There's a different body turn, completely confused. No wonder the father is very upset. Boy is getting the seizure every day, many times in the night. And this is the problem. So this is also a seizure, a focal seizure with impaired awareness. Right? And sometimes some of the seizures can be very brief and it's very emotional. And you see this girl. See, I'm talking to this girl. We are asking the history. Suddenly, see, she becomes normal. What is your name? So you see that? So this is an emotional seizure where they suddenly have some extreme fear, and this extreme fear can come from the frontal lobe, orbitofrontal cortex. And she had the problem in the orbitofrontal and the cingulate cortex, and she will suddenly become very fearful, and she will have this frightening. You can see that she's panicked, and so that's what it is. I showed you a spasm which was generalized spasm. Now I'm going to show you a spasm in a child who's just only 3 months old, 4 months old. You just see what happens. This is an asymmetrical spasm. You see that only one hand is getting involved. You see this hand. You see that the left hand is not involved. The right hand is going away. And when you see a focal spasm, you know that there's an abnormality on one side of the brain, and you can see that. So that's how a focal seizure can be. And sometimes seizures can come because of some precipitants, or what are called reflex. And the commonest reflex epilepsies are when somebody is eating. This is a girl who, I'll show you a girl who's eating. You can see this. Every time she gets a seizure, it's when she's eating. And you can see that. I recorded this. Just see, she's having a meal. And as she's having a meal, suddenly she becomes stuck. She becomes absent. See, the father notices, oh yeah, this is a problem. And you see, focal unaware seizure, because he's asking her questions. She's not able to answer. She stopped eating. She becomes silent like a completely dense loss of awareness. Father is asking her, okay, come on. She's asking her questions. She's not able to do anything. and slowly the head goes to the left. And now this is a motor film. So initially it was non-motor, now it is becoming motor, and then it becomes generalized tonic-clonic. So this is a typical reflex eating epilepsy. So that is what it is. Now this is another man. Every time he puts the foot on the ground, he'll fall down. You just see this. That's called sensory reflex seizure. You can see this. See, we are recording. You just see, we are asking him to put the left foot and it bends his arm. So that's called, it's a very unfortunate. He's not able to walk at all. He's not able to walk because every time he steps with the left foot, he puts on the ground, he'll just, the arms and the legs become stiff and he'll fall down. So multiple injuries. So these are called reflex. Every time there's a sensory reflex that triggers a seizure. Either it's an eating or it is the contact with the ground. So all these things can happen. Now we are coming to the topic itself. So I just wanted to familiarize yourself with what is a generalized seizure, what is a focal seizure, with some examples. Now we'll see what we should be doing when you see, now we have a lot of medications. You see there's a big list of medicines, but you should know how to use these medicines properly. So there are some agents which can be used for both focal and generalized. That's what they're called broad spectrum drugs. Then there are drugs which are best for focal seizures, but they're not very good for generalized seizures. So if you have this concept in mind, then you can choose the medications appropriately. So that's what it is. So let us now start when a patient walks into the ER or is brought to the ER or walks into the OPD. So let us see what are the questions that we have to ask. First thing is, was the attack truly a seizure? Because we showed you some non-epileptic seizure. Also, we showed also something which is psychogenic, or it could be physiological non-epileptic seizures like syncope, etc. So was the attack truly a seizure? Then you'll have to ask, is this seizure the first ever seizure of the patient? Next, I said that you should always ask the question, why did it happen? Which means you must understand the etiology. And most importantly, was the seizure a symptom of an acute neurological or medical illness? For example, let us say the severe high blood sugar, 500, 600, and having a seizure. Well, that is because of a medical illness. Or a remote neurological injury, head injury 10 years back, and now having a seizure, you know that it's coming from a scar. So that is what is important. Then the next question is, how much to investigate? Nowadays, any patient who walks into the ER, they get investigated extensively, when actually 90% of the investigation is not required. So because each of these investigations are expensive, so the extent to which one investigates the patient is purely based on that particular patient. It's highly individual specific. It's not just you do a battery of tests, no. So, and then you must always ask the question, is this going to be a single episode or is there a likelihood of a recurrent attack? Now, there are some examples of that, I'll tell you. The next question is, will treatment with anti-seizure medication significantly reduce the risk of subsequent seizure? That we have to ask. Is this really needed? So if in some situations I'll say, okay, no, in a small child who has had a benign rolandic seizure, I will say, I'll reassure the parents, no, there is no need to treat, don't bother. And because every time you start a treatment, there's always some, some side effects due to medication also. So that's the reason why we have to be very careful when you start somebody on long-term medication. Does the patient really require a long-term medication? And the most important thing, I showed you about the broad spectrum and the narrow spectrum drugs. You have to choose the medication rightly and wisely because it should be appropriate for the patient. And that's very important. And again, now, if somebody has come into the ER or the outpatient and says that, I'm a known epileptic patient, but now I had a recurrence. So now I have to find out, why did the patient have recurrence? So that questions are different. The questions are, okay, you already have a diagnosis of epilepsy made, but now I want to know why you had a recurrence. So I will now go through this checklist. Did the patient not take the medicine properly? That's one of the most important causes. The next important cause is I'm taking the medicine regularly, but my sleep was disturbed. I've not slept for more than 3-4 hours the previous night. Very likely the patient is likely to have or overuse of alcohol. And then I'll decide whether this is a focal epilepsy or a generalized epilepsy, because then I'll decide whether that anti-seizure medicine is appropriate for that particular epilepsy. And once I've chosen that, then I'll have to decide on what is the correct dosage. And always I will ask the question, was it even in an epileptic patient can have a non-epileptic seizure? It's quite common. So there is a 25% of patients who have epilepsy also have non-epileptic seizure. So that's what it is. So in a patient who is already known to have epilepsy, there's no need to keep on doing neuroimaging all the time. There's no need at all. Can be managed in the OPD after initial. Even if the patient has come to the ER, you can send them off to the OPD. That's all. Say that, okay, no, there's no need to go. So the classification of a first seizure, is it a provoked seizure? I told you already that it could be toxic, metabolic. Is it a symptomatic seizure because of a traumatic brain injury or encephalitis? An acute illness. Remote symptomatic. Acute symptomatic is because of an ongoing damage to the brain. Remote symptomatic means some time ago there was a brain damage and that has recovered, but the seizure is a consequence of that. And finally, seizure associated with epilepsy syndrome. Now I'll give you some examples. Nothing better than examples. Now, this is a 15-year-old male. All of them are patients. So, this patient reaches the ER after having suffered a generalized tonic-clonic seizure 30 minutes ago. Now, we'll have to ask whether this is a focal seizure or not. If it's a focal seizure, they'll almost always have an aura. And this fellow said, no, I didn't even know why it happened. So that's all. No recall. So it lasted about 5 minutes. According to the history, it was the first seizure. So this patient has had a first seizure. So the first seizure by history and generalized tonic-clonic. So we know it's a generalized seizure. First generalized seizure, the person is otherwise completely normal, no constitutional signs, no acute neurological illness going on, no metabolic other things. Now, this is not epilepsy. This is a first seizure. But I do an EEG. And in the EEG, this same boy, 15-year-old, his EEG is abnormal. His EEG is showing generalized spikes. So this is a situation where I just told you that even at the end of one seizure, you can make a diagnosis of epilepsy. So this boy is likely to get another seizure if you don't treat him about 70% of the time in the next 1 or 2 months. So do you have to wait for the second seizure? When I see this EEG, I know that I have to treat him today. I don't have to wait for the second seizure. So I treat. And when history was reviewed, because I saw this EEG, I asked him, do you get some myoclonic jerks? I showed you the myoclonus earlier. Then he said, occasionally if I'm sleep deprived, I get. So that is the epilepsy syndrome. In him, the epilepsy syndrome is a normal boy at the age of 15 gets the first seizure. He may have had a few myoclonic jerks here and there. So this is a condition called juvenile myoclonic epilepsy. That's the epilepsy syndrome. Now, if it's a boy, so the best drug for this is sodium valproate. You should not use carbamazepine. You should not use phenytoin. And when I see this EEG, I know that I don't need to bother about urgent neuroimaging at all. I don't need a neuroimaging for it because the EEG shows generalized tonic-clonic, generalized polyspike. So that is how we tailor. So we started on. Now, this is an acute symptomatic. What is an acute symptomatic? Acute symptomatic means if a seizure happens within 1 week of an acute insult to the brain, which is a stroke, could be a traumatic injury, could be anoxic encephalitis, intracranial operation, whatever it is. And it's during the active phase of the central nervous system infection, within 24 hours of a severe metabolic derangement, and acute symptomatic seizures are a very common cause. So we all have to know about it. So a 15-year-old male, see this is another scenario, came to the ER with a history of recurrent left focal seizure He says he gets some kind of funny sensation in the hand, and then it progresses and involving the left face, left upper extremity, many episodes, fully aware, mild. At the end of the seizure, he may have some mild weakness of the hand for some time. That's called the Todd's paralysis. And between the attacks is normal. So we know that this is an acute symptomatic seizure because it's a focal seizure, which is completely all right. So in this patient, unlike the previous patient, the first investigation is not the EEG. The first investigation here is neuroimaging. You see, in the previous patient, you didn't need neuroimaging. In this patient, you will need neuroimaging. And EEG is not going to be contributory. So here, I do the neuroimaging, and I see a very nice neurocysticercal cyst in the parietal region. That's why you got that sensory motor seizure. That's the problem. So you treat the symptom. You don't need to have an EEG for this. So here, it's a focal syndrome. Previously, we said that carbamazepine, phenytoin should not be used. But here, the drug of choice here is carbamazepine or phenytoin or phenobarbital or some broad spectrum drugs. So see the difference in management and see the difference in approach to the investigation. Now, this is another girl. See, this is a 14-year-old girl. Sudden onset, acute onset. See, she was completely normal. Explosive onset of continuous focal seizures of the right face and right hand. The previous patient was left face, left hand. But here, in between, the patient was normal. Here, this patient has got continuous seizures. But she is fully conscious. Speech has no dysphagia, but has dysarthria because continuous jerking of the tongue. I will show you that. Previously well. You see this? The tongue is continuously jerking. This is called epilepsy partialis continua. Face is jerking. You see the speech is slurred.
Which class are you studying?
See, she's a 12th standard girl. Sudden onset. You see that jerking of the face and some jerking of the hand also. You see that twitching of the thumb. So this is continuous epilepsy partialis continua. Here, neuroimaging is the first thing.
Okay, very good.
So she's fully conscious, aware, focal aware seizures. And we could see some hyperintensity in the left side. And this is an acute focal encephalitis syndrome. And in her, we found that it was an autoimmune encephalitis, focal encephalitis. So GAD was positive in the CSF, and she was treated with methylprednisolone. She was given rituximab. And you see, when we give rituximab, see, after 2 weeks, completely normal.
Huh? And the jerks are only
see this? You see, she didn't require any anti-seizure medicine at all. She needed only inflammatory drugs, anti-inflammatory, normal, completely normal. You saw that? So the approach is different. So now we'll come to postpartum seizures. And my colleague here is looking at the optic fundus, which is a very, very important finding that you get. It's a 25-year-old. This is a 25-year-old. 5th day postpartum, she had 3 generalized tonic-clonic seizures within a span of 6 hours. She had headache. She had intermittent blurred vision. BP was 150/100 in a young woman. This BP is very high. Urine showed proteinuria. My colleague found papilledema, no lateralizing deficit, conscious patient, but severe headache. And this is the findings. You see these hyperintensities in the posterior head region. And this is what is called postpartum eclampsia with posterior reversible encephalopathy syndrome. PRESS, it's called. Here, it's not even though she has had seizures, we give magnesium sulfate and no need for giving anti-seizure medicines. And blood pressure reduction, that solves the treatment and she becomes normal. There's another way, sometimes you get in the same postpartum period, you get what is called cortical sinus venous thrombosis, and that could produce an acute symptomatic seizure. And here you see Vera's 28-year-old woman who had a headache, vomiting, left focal seizures, and mild left hemiparesis, papilledema. Here the treatment is anti-seizure medicines, but also heparin, low molecular weight heparin, acetazolamide to reduce the CSF pressure. So that's the way in which you see so the seizure is the same type, but the management is completely different. Now, sometimes you get this confused patient who has come to the emergency, 72-year-old, mild, stable chronic renal failure with a creatinine of 2.5. The history is that last 3 2 days she's been very dull, slow reaction, low grade fever, she's very confused. And Cefepime was given. You see this lady, she's conscious, but she's very, very slow. See, we are asking her name. She's not answering, but she's keeping her eyes open. She's partially responding. You see, she's. This is absolutely, she's very encephalopathy. This is called encephalopathy. She's. Now she's doing. You see, it takes her 5 commands to obey once. So very slow cerebration as it's called. And so this is what was going on. She can be actually made to sit up and all that. So she's not. So she's very slow in her reaction time. And what we found was in this EEG, we found that she had continuous seizure activity inside the brain. Now outside, it was manifesting only a slowness of brain activity. But inside the brain, here the EEG was very important and it showed non-convulsive status epilepticus, non-convulsive status epilepticus. And the culprit, Cefepime. Cefepime is an antibiotic which can induce a non-convulsive status epilepticus in an elderly, especially when there's a mild renal failure. So that is what it is. And you see, 24 hours after, see, she is now normal. See, see, she's absolutely normal. She's absolutely normal. And you see, the EEG has become normal just by withdrawing the drug. So that is how it is. You see, this is another patient who has come to the outpatient, to the ER. 10 years of diabetes, irregular medicine, last 36 hours, repeated episodes of confusion. You see this patient. You just see what is happening. We diagnose this in the ER. You see that the eyes will slowly drift to the left side. He is confused at the time. And and then there's what is called an ictal laughter. And the eyes will show some nystagmus. You see this nystagmus? That's an epileptic seizure that is happening. And that means you know that it is coming from the right occipital region because the eyes are going to the left side. And the EEG, we recorded the seizure which is coming from the right occipital region. And you know why it's happening? Because of this blood sugar which was 600 urine. So this is a non-ketotic hyperglycemic seizure. This is an acute symptomatic seizure. And this is how the MRI will look as a very, very typical of this hyper. And then the EEG becomes normal. Once the blood sugar comes down, the patient is normal. Finally, it's very important to understand that all the seizures that happen need not necessarily be epileptic seizures. And this is a very, very good example. This is one of our good cases that we had recently. 33-year-old woman brought to the ER with a history that she's been having prolonged generalized tonic-clonic seizures, each lasting for 10 minutes at night between 11 p.m. and 11:45 p.m. So that means it's a status epilepticus by definition. She lives alone with 3 other mates and married but separated. So there's a lot of, history like that. Taken to a nearby hospital, loaded with, full doses of medication because of thinking that this is likely to be a status epilepticus correctly treated. 1.5 grams of phenytoin, 1 gram of levetiracetam, 4 milligram lorazepam. And but the CT was normal, blood works were normal. Because the seizures were not getting controlled, she was referred to us. When she came to the ER, she was shifted to our ER and I was there to receive her. And this is in the outpatient clinic. And something in me told that this may not be an epileptic seizure. So what I tell this girl is that, okay, you may get a seizure now. So I'm going to, kind of stimulate your forehead and you may get a seizure now. And just see what is happening. See that? She starts jerking. I'm just suggesting that you may get a seizure. You see that? She started getting a seizure. And they said that this is the seizure that she gets, for which she has received, so much of anti-seizure medicine. See, they're telling that this is the same type she gets.
Yeah, it was much more severe.
You see that? So, this patient has status epilepticus, but it is a status non-epilepticus. This is not an epileptic status. It is a non-epileptic status. You see that? Okay, so I'm going to say now, she's going to continuously jerking. I said I'm going to stop it. I'm going to remove the current from the back of the head.
It will stop. Yeah.
And I'm telling you it's going to stop.
Slowly it will stop.
And slowly it may die down. You see, slowly settling down. Now it has settled down.
Very good.
See,
Very good.
it didn't require anti-seizure medicines.
Yes.
It required some suggestion that it's going to stop. So this is a very good example that all that shakes is not epilepsy. All that shakes is not epilepsy. Right? So now finally, this is the last case. It will take another 3-4 minutes. That's it. And I'll just show you what is an epilepsy syndrome and how we approach it. This is a girl, 13-year-old, from the age of 7 has been having seizures. And you see this this cluster of symptoms. She feels some epigastric rising sensation, as if something is rising from the stomach. Then she becomes blank. Then she becomes unresponsive. Then she's confused. And she's on 4 medicines, no effect. She's affecting her studies. And we found that on her MRI, it showed, it's coming from the left side. There is a sclerosis of the left mesial temporal, or this is a hippocampus. And when the hippocampus is involved, you get this epigastric rising sensation. So we know that this is a temporal lobe, medial temporal lobe epilepsy. And we do an EEG that showed left temporal spikes. And we recorded the seizure. This seizure that this 13-year-old is having, and she's confused. She's completely confused. And what is called automatisms of the hand. This is automatisms of the hand. My technician is trying to contact her, but she's not able to respond. She's looking at him, but she's confused. So this is a classical temporal lobe seizure. Right? So that's what it is. And we confirmed that it is a seizure during that episode, very nice rhythm. And then we operated on her. So we removed the diseased temporal lobe. You see this? This is the operation. We have removed that particular area which is abnormal. And after we removed, long back, I mean, this we did it 10, 11 years ago. And you see this girl is normal now. She is completely normal. And we have stopped her anti-seizure medicines. So this is what you can do with seizures if you analyze them properly. And so that's what it is. So in summary, management of seizures in the outpatient and ER needs an individualized approach. I showed you good examples of how the seizure is the same, but the therapy is different. The investigation set is different. And very importantly, to need to distinguish between epileptic seizures and non-epileptic seizures, investigations have to be tailored based on the clinical scenario. Anti-seizure medicine choice depends on the type of seizure, whether it's a focal seizure or a generalized seizure. And specific treatment depends on the etiology. Because you saw that autoimmune epilepsy, the etiology helped us to decide what medicine to give. So thank you very much.